Okay, so good morning, everyone, and good evening to those who are in the U.S. So today is Monday in the U.S. and Tuesday for us here in Manila. And every Monday we have our doctor's training call. Okay, so for today we'll be having Dr. Mario, who will be discussing all about foot care in diabetic feet. Now, joining us also today, of course, we have our president, the father of Forever Healthy Products, Sir Leon Katz. Of course, we have Dr. Arlie. Good morning, Dr. Arlie.
Good evening, America. Good morning, Asia. Take advantage of our weekly doctors forum. It's like having a free medical consultation, and we focus on prevention. And the topic today is so important because diabetes is very pervasive, and everybody should learn how we can prevent it. So I look forward to a fruitful lecture with Dr. Mario today. Francis?
Thank you very much, Dr. Arlie. Okay, maybe I can pass this now to Dr. Mario. Dr. Mario.
Yes, thank you, everyone. Thank you, Sir Leon. Thank you, Francis. Thank you, Dr. Arlie. And thank you, everyone, for joining. What we're planning today is not what I'm training you today, I'm showing you today is not to scare you. And let me just give you information that the videos you are about to see and photos you are about to see are kind of graphic. So I suggest you turn away once you get to see, once I get to show you some of the photos. This is what I do. Okay? I do a lot of surgeries before, and one of the things you have to understand is that I can do a below knee amputation for anywhere between, the cheapest I can do it is I can do it for 15,000 pesos professional fee, and I can cut your knee in 15 minutes. Okay, below knee amputation, I can do that in 15 minutes. So that's basically 1,000 per minute. And before COVID, I was doing like about 2 to 3 a day. Yeah, I can do 2 cases, 3 cases in an hour.
Do you take your Immune Plus before you operate?
I do take my Immune Plus before I operate, and I'm happy to say that I'm actually sad to say that because of Emergen, now I only do 1 amputation a week. Very bad. I'm not making that much on amputation, but thankfully, because of the advent, because of the motorcycle companies, they are making me rich because of a lot of motorcycle vehicular accidents I'm getting these days. So let's get on with it. Let's get it on, as they usually they say. Right, and let me share you my slide. Okay, I wanted to tell you, talk about diabetic foot. This is a corollary to what Dr. Oclarit was discussing, the pathophysiology of diabetes. I delve specifically on diabetic foot because I have had a lot of cases of diabetic foot, and let me show you the incidences. Before anything else, there's a disclaimer I want to tell you. This presentation is for educational purposes alone. There is no attempt to diagnose, treat, prevent disease, or cure disease. If one has a medical condition, the best thing you have to do is to consult your physician. Health statements have not been evaluated by the Food and Drug Administration. Let's get that. So before anything else, let's do this video.
Why do you think he lost you?
I think he did not understand me enough. He was not in touch with my needs.
Can you explain more?
He didn't know that I might not get enough blood or heal very easily if I got hurt. He should have cared for me more.
And how did you want him to take care of you exactly?
Well, he should have checked me every day, looking for redness, ulcers, cuts or bruises, at pressure areas, my heel and between my toes. And when he noticed any of these, he should have immediately asked for help from a specialist. He should have kept me clean and dry and moisturized my skin.
Okay. Anything else?
Yeah, he should have avoided me coming into contact with overly hot or cold surfaces, and never walked barefoot, as I couldn't feel if I was hurt. He could have taken more care when cutting my nails. I wish he had avoided shoes made of plastic, sandals, flip-flops and high heels, and used dry, thick cotton socks. But instead, he wore very tight shoes with not enough room for me. I don't think he cared if he kept me or not.
Do you think he has any chance of getting you back?
Unfortunately, not.
I hope you guys enjoyed the quick video. This is a video of separation between a foot and its owner. And I find it funny. And it is actually a fact that what he said, that there are things that they said can cause you to undergo an amputation. So what is first a diabetic foot? It is an infection, ulceration, or destruction of the deep tissues associated with urological abnormalities, various degrees of peripheral vascular diseases in the lower limb. This is based on the WHO definition. The epidemiology of the diabetic foot, it accounts for 40 to 60% of all non-traumatic lower limb amputation. 40 to 60 non-traumatic lower limb amputation. Imagine that. So it's very, very, very common. That's why I was telling you, I did a lot of amputations, and I honed my skill in below knee amputations because of diabetes. Because number one, the reason why I wanted to do it quick is because number one, diabetic gangrene and infected diabetic lower limb extremities are so foul smelling that I have to finish it as soon as possible. That is why I can do the surgery in 15 minutes. And what I usually do is that I do schedule my diabetic foot and gangrenous foot amputation one after the other, because after that surgery, the operating room has to undergo thorough cleaning. Okay, you cannot use it for a clean case, otherwise it's going to become that clean case is going to become infected. So we schedule a diabetic foot usually on an off day, and we schedule it together. So if there are cases of diabetic foot, particularly in Philippine Orthopedic Center, we have a dirty OR, an OR which is specifically for gangrenous foot and dirty surgeries, and we use that for amputations. It's 85% of the diabetic related foot amputations are preceded by foot ulcers. So you can see the high incidence that foot ulcers can cause amputation. 85% of that. 4 out of 5 of the ulcers in diabetics are precipitated by trauma, because patients with diabetic foot do not recognize pain. They have a peripheral neuropathy wherein their foot is actually does not feel very well, and some trauma, some cuts, some abrasions, some small cut can be infected and develop into a big ulcer, suppurative ulcer. 4 to 10% is the prevalence of diabetic foot ulcers in diabetes. So here are the factors associated with diabetic foot: previous ulcerations or amputations, particularly the ipsilateral limb; neuropathy, which is a sensory motor neuropathy; trauma because of poor footwear, walking barefoot; falls, accidents, objects that are being inside of the shoes, too tight the shoes; biomechanics, limited joints mobility; the bone prominences, which can cause deformity or osteoarthropathy; calluses, which can become secondarily infected; associated peripheral vascular disease like Reynolds phenomenon for those who are diabetic and smokers; socioeconomic status like poor low social position, poor access to healthcare, non-compliance or neglected diabetic foot, and poor education. So in terms of the social and economic factors, diabetic foot complications are very expensive. The cost of healing is about 7,000 to 10,000 USD. The International Diabetes Federation, IDF, reports that the mean overall diabetes-related expenditure per person with diabetes in the Philippines has increased from $61 in 2013 to $234 in 2017, indicating a growing financial burden. Right now, I think it's already in the almost $400 range. So pathophysiology of foot ulceration, number one, there is neuropathy, which means that the foot had nerve problems, ischemic changes, there are vascular changes in the lower limb, and a combination of both neuro and ischemic changes. So these are common, particularly in patients with diabetic foot ulceration. So let me show you a flow chart on what we do. A diabetic foot will have either a neuropathy, which involves the nerve, or angiopathy. The angiopathy might be, which involves the circulation. Angiopathy may cause microangiopathy, meaning there is poor small vessel circulation, which could lead to ulcers, to foot ulcers. And there are the big vessels, the peripheral vascular diseases leading to ischemia, gangrene, and amputation. The foot ulceration, if neglected, will eventually and become secondarily infected, lead to amputation. Whereas the neuropathy may have a motor, sensory, or autonomic nervous system involvement. The motor involvement can cause limited joint mobility, postural and coordination deviation, decreased pain because of sensory neuropathy, autonomic, in which there is diminished sweating, altered blood flow regulation, dry skins, which causes fissures, and added to this, the foot deformity because of the motor problem can cause calluses. Then the trauma is included. When trauma and callus come together, there could become foot ulcerations and would lead to amputations. So the stages of ulcer development, number one is that you can see that there is drying of the skin, then there is callus formation. After callus formation, we have what we call a subcutaneous hemorrhage, wherein because of ill-fitting shoes, and because I will be explaining this diagram later on. And this illustration, as you can see that the toe is kind of bent. It is called hammer toe. It's common for people who use tight-fitting shoes, those with the high heels and women with tight-fitting shoes. This subcutaneous hemorrhage can cause breakdown of the skin. And upon breakdown of the skin, the infection deepens and goes deeper and deeper into what we call an osteomyelitis. So again, here's the pathophysiology of hammer toe, wherein there is excessive flexion deformity in the proximal interphalangeal joint of the great toe, the big toe, and it looks like a hammer. And this deformity can cause ulcerations because of pressure inequality, because the pressure is actually more on this parts, and the big toe, and this can cause damage on the soft tissue underneath the deformity. And here on top of the PIP joint, there can also be some trauma, because if there could be some deformity, because this could be caused by bad footwear that you can see, which I will show you later on. Again, here is another patient with a very bad hammer toe. Okay, they're crossing. She was crossing her toes, just hoping that her feet will look better because of high heels and a very bad hammer toe. With diseased nerve, there is either a poor sensation plus dry skin, which leads to the problem, imbalanced musculatures of the toe, deformed toes, abnormal pressure points, and leads to ulcers. Diabetic neuropathy is a sensory motor peripheral sympathetic neuropathy, are major risk factors for ulcers. History and careful examination are mandatory to keep the neuropathy at bay. Up to 50% of type 2 diabetics have significant neuropathy and risk of foot ulceration. And peripheral vascular disease and diabetic peripheral vascular disease may be two different things. We have such a thing as a Raynaud's phenomena because of smoking. It's a peripheral vascular disease wherein blood flow to the lower extremities are hampered. It is the most important factor related to the outcome of diabetic foot ulcers. We use or do angiography to find out the level wherein we can safely do an amputation, because if the level is, we do it very at the low level, that amputation can fail and we have to do a higher level amputation. Peripheral vascular disease is diagnosed by a simple clinical examination. Non-invasive vascular tests includes determines the probability of healing. This test, we just do the blood flow test. You can see if there is ischemic changes already in the toes. Symptoms of ischemia may be masked by neuropathy because the patient cannot feel. Microangiopathy, which is problems in the small blood vessels, shouldn't be accepted as the primary cause of diabetic ulcers. It is usually there are more bigger blood vessels involved in ulcers. Conservative approach for treatment could happen if diagnosed early. Outcome for revascularization is similar to that of non-diabetics. Biomechanics of footwear. Biomechanical abnormalities are consequence of neuropathy. They lead to abnormal foot pressures, can cause the ulceration later on. Foot deformity, neuropathy are increases the risk of ulcer. Pressure relief are essential for ulcers. That is why it is important for you guys to be wearing loosely fitted, shoe wear. Do not use very tight shoes. Frequent inspection of the shoes. The insoles are mandatory because any abnormality in the wear of your sole can manifest and can later lead to foot ulcers. So appropriate footwear again is important to prevent the recurrences of footwear. So let me show you the biomechanics of the footwear. You can see on the right, this is the normal, wherein pressure is evenly right top. You can see the pressure is evenly applied on all the surface of the sole of the foot, whereas in hammer toe, their pressures are in the distal joint, and PIP, the proximal interphalangeal joint, and the calcaneal part. So there are three pressure points that can cause ulceration. More severe hammer toes, you can see there are a lot of pressure points, and interphalangeal pressure points, because of the interlapping of the toes, can cause more aggressive and more severe problems. So the footwear, you can see the difference between a very tight footwear and a loose footwear. You can see here in the left, when the footwear is so tight, you can see that the toes are compressed together, whereas if they are left, the normal, it is usually very loose, and it doesn't do well if the shoe wear is so compressive in the front part of the shoe. Infections and diabetic foot infections is limb-threatening and often life-threatening, because if we do not remove it, the patient can die. And the signs of infection may be absent in diabetic patients with foot ulceration. Superficial infection is usually caused by gram-positive bacteria like E. coli, okay, a gram-positive bacteria coli. Surgical debridement is important for removing the dead skin surrounding the deep ulceration so that it increases the possibility of healing. Osteomyelitis should be diagnosed early and treated early because otherwise it's going to lead to gangrene. Amputations of diabetic foot increases minor and major amputation, increases the number of deformed feet. Minor amputation is needed for gangrene as part of the debridement policy and for correction of the foot deformities. Minor amputation does not significantly compromise the ability to walk. Minor amputation, we just remove, for example, a toe. All right, we just remove the big toe, then keep the other toes intact. Major amputation, we remove a big part of the foot or do a below knee amputation. The risk of loss of ability to walk is high. There's also higher mortality rate, high risk of contralateral amputation, meaning the ipsilateral or the other side sometimes can also be amputated. There are strict indications in the amputation. Careful choice of the level is important because I have had cases wherein the level was done too low. The wound healing was not good because number one, the peripheral vascular disease, as I will show you later, the blood flow to that area where the level was too low or amputated too low was poor, and a poor blood flow is an indicator that it will not heal properly and just get reinfected. Then we do another amputation at a higher level. So I have had and seen cases that patients from different residents in the Philippine Orthopedic Center, they did 3 times amputation, three times higher and higher and higher until they had to do above knee amputation. Very bad for the patient. So how to prevent foot problems? There are 5 cornerstones. Regular inspection is the easiest, and you have to examine your feet and your footwear because there are things that could happen if you are not vigilant in trying to find out and inspect your feet. Identifying high-risk patients, particularly those with poorly controlled diabetes, education of the patients, the family, and healthcare provider is also appropriate, and the use of appropriate footwear, loosely fitting footwear, then immediate treatment of a non-ulcerative pathology. That means that if there is beginning ulceration, you can see there's a beginning problem, then immediate treatment should be done. This is one of the examples. You can see crusting and already infection. There is already infection in the center here. This infection can spread and cause osteomyelitis to the phalanges, the metatarsal bones. And when we have to do an amputation. Here you can see an angiography we can do and see that the foot is poorly supplied by blood vessels, and when that happens, it usually ends up in an amputation. Another gangrenous foot, you can see this is particularly because of the level of peripheral vascular disease. There is very poor blood supply and infection causing death of the toes. We usually do a higher amputation here because we evaluate what level has good blood supply, and we amputate at that level. If we amputate, like for example in the ankle, we do permit maintaining the length of the leg, but again, we risk the chance of having poorly healing amputation stump that will cause a problem later on when the wound gets infected and you have to do a repeat amputation. So the biomechanics of the footwear is that biomechanical abnormality are consequences of neuropathy. They lead to abnormal foot pressures and later foot ulcers and increases the risk of ulcers in the foot. Pressure relief is essential for ulcer healing and prevention. So you have to frequently inspect your shoes and insole, and appropriate footwear reduces the chance of ulceration or the recurrence of ulcers. Okay, let me show you what we do. This is a CT angiography, and you can see from letter A vision, you can see that the blood supply to the foot is already very, very bad. This is a very bad case of peripheral vascular disease with diabetic ulcers. And you can see at the ankle already, there is already almost no blood supply going to the foot. The same thing in the middle picture. There are still some blood vessels going to the foot, and the level of the amputation usually would be indicated for a B and C. We usually do a below knee amputation at just about mid-leg. Whereas here in A, we either do a knee disarticulation or better still is to do a higher above knee amputation. As you can see in letter A, the vascular angiography, the CT angiography shows that there is a blood or a disruption of blood supply of the femoral artery, and there is bypass already, and this disruption can cause problem in healing, particularly for those below knee amputation. So it is sometimes prudent to do a high above knee, mid thigh at this level, because at this level the healing would be even better. And you can see here, there's a callus formation which could become infected. There are fungal infections, and that callus formation can lead to an ulcer. And these are examples of footwear. We free the front part, the toes. And another complication is the osteomyelitis. There is infection growing at the level of the big toe, spreading to the bones. And you can see here the lower part is that the part of the bone has been eaten by infection. Diabetic foot ulceration treatment modalities is antimicrobial control. We give antimicrobials, wound control, vascular control, mechanical, metabolic, educational control. Also, nutritional control. It's imperative that nutrition should be added, and high value supplements could be given because they are important in preventing microbacterial infection. So here are the stages of diabetic foot. Stage 1 is normal. Stage 2, high risk. Stage 3, ulcerated. Stage 4, there's surrounding infection of the soft tissue, so it's cellulitic. Stage 5 is necrotic, and stage 6 is major amputation. The assessment of the diabetic foot, you assess for neuropathy, meaning you assess for nerve, sensory and motor nerve problems, ischemia, blood flow, deformities of the toes, callus formation, because a lot of callus can cause, or a thick callus is an indication that there is something wrong already with your foot, swelling, skin breaking, infection, and necrosis. So I want you to listen to this video before we proceed.
Your feet work hard every day. People with diabetes should be vigilant about proper foot care.
Foot care is really important for people with diabetes because of the risk of a diabetic foot infection, which typically starts with a peripheral neuropathy.
Mayo Clinic Dr. Elizabeth Cozine says peripheral neuropathy is a common complication of diabetes. It means nerves in the foot are damaged and people can't feel pain. Some diabetics also have poor blood flow to the feet, which slows healing.
So if they have a minor injury, there's a possibility of it turning developing into a major injury or infection.
The following 5 tips can help people with diabetes keep their feet healthy. Inspect and wash your feet daily. Be careful when you trim nails. Wear properly fitting shoes. Don't go barefoot. And take steps to manage your diabetes by eating right, exercising, monitoring blood sugar, and regularly taking your medications. And if you do notice any sores on your feet, act fast and see your healthcare provider. For the Mayo Clinic News Network, I'm Vivian Williams.
Okay, that's a Mayo Clinic report, short report. There's a specialty called podiatry, which is a foot doctor who specializes in diabetic foot or foot problems. We usually, the podiatrist usually do is to clean diabetic foots. They debris the wound, the surrounding wound of dead callus and necrotic tissues so that the wound is able to heal properly. Now, because if you do not debris, what will happen is that the infection spreads into the deeper tissues, to the soft tissues, then into the bone. Here we do high below knee amputation. Again, another diabetic foot. You can see here is already pressure necrosis at the distal toe, big toe, and some pressure necrosis at the other distal parts of the other toes. There's also pressure sore here. An ulceration is caused by the pressure sore, and this toe and the rest of the toe has to go. All right. Sometimes when we remove it, there is already the possibility of healing, but then we have to be aggressive in trying to prevent recurrence and infection. These are more extensive problems. The necrotic tissue is under the necrosis, or the necrotic tissue is more extensive. It is actually in the deeper muscle layer and the tendons already. Again, here in the soft tissue, the dorsal aspect of the toe of the foot, you can see an abrasion, abrasion, and later became infected. So the dysvascularization of the foot breakdown, the natural history is that there are usually in grade 0, there's usually no lesions, no open lesions. Then it starts with grade 1. There's a superficial ulcer which becomes deeper and progresses to grade 2. Then abscess is formed, and abscess or cellulitis is formed. It's already grade 3. The blood vessel or the blood supply is compromised, leading to a gangrenous distal foot, okay, which is grade 4. And when the whole foot is already gangrenous, it is a grade 5. All right. Here you can see a lot of infections that can cause already very bad spread of the infection to the other parts of the foot. And you can see that infection can cause on the lower part. This infection can cause damage already to the bone and cause infection called osteomyelitis. And here you can see another osteomyelitic infection. When we treat it early and prevent it from spreading, we could manage to save the big toe. You can see on the right reformation of new bone, and with antibiotics and boosting your immune system, we were able to save that leg, that foot. Again, a very bad case of an infected ulcer. Another infected ulcer after a post amputation, ray amputation. Other ray amputation, we remove the 4th and 5th digit, and what happened is that the patient is still able to walk and use his shoes. Here we did an ankle. This is an ankle disarticulation, okay, because the ankle stump healed well. Thank God that the vascular, you can actually see when you operate in it when you cut at the ankle, there is already fresh bleeding. That means the blood vessels are still intact. But if the bleeding, there is no fresh bleeding and bleeding is not that good, you have to amputate on a higher level. And this is a metatarsal amputation at the metatarsal level. The nice thing about this is that the foot length is maintained and the patient can still wear footwear. So these are the different kinds of amputation. Amputation at the metatarsal level, Lisfranc, which is amputation at the higher mid metatarsal area. Choparts, no, it's amputation at the calcaneotarsal level, and ray amputation when we just do one amputation of one segment of or one toe. It's called the ray amputation. Okay, here are the different kinds of amputation. Metatarsal is the metatarsal area. Lisfranc at the small joints, bones of the foot. Chopard is at the tarsal bones, prior just in front of the calcaneus. Pyrgoff and Boyd at the calcaneal level. The nice thing about Boyd, although it is a very difficult procedure, at the same time it's very difficult healing. The Boyd, you maintain the plantar length and the plantigrade of the foot. Symes and amputation is when we do it at the ankle already. It's like an ankle disarticulation.
Well, here we're looking at some classic diabetic foot callus. You can see the hard patches of keratinized skin. And this has occurred in several places over the surface of this patient's foot. Here we see some under the toenail, and the suspicion has to be that there's a pressure area and an area of infection underneath this area of hard callus. Here we see some hard callus which has been peeled off, and this can be now cut off, and this wound can be allowed to heal by secondary intention. But you've got to get rid of the hard callus on top first to open up the wound, so you can then get in to heal it by secondary intention. Well, here we see a particularly severe case of peripheral vascular disease. The dressing covers an injury which wouldn't heal due to ischemia. You can clearly see the black necrotic tissue on the toes. The patient's already lost the other limb due to peripheral vascular disease, requiring amputation. So we see the black necrotic areas where basically there's no blood getting to at all, and the areas have simply died. This toe is essentially dead tissue now. It's gangrenous. Essentially the toe is decomposing. Significant discoloration of the foot. This patient was actually systemically confused. Bacteria from the decomposing area was getting into the systemic circulation, giving rise to the risk of a systemic blood poisoning. A little bit of gauze there to try and stop the toes from rubbing together, but didn't make any difference really. This limb actually required amputation shortly after these shots. No pulse palpable there on the foot. I couldn't feel anything at all actually. Posterior tibial again, I couldn't feel anything at all. This was the end stage of a long-term disease process. It wasn't acute, it was a long-term ongoing chronic condition. that deteriorated to this level of severity in a diabetic patient. We can see here that part of the great toe has already been removed, and that the second toe is showing significant discoloration and infection. And this infection has spread to an area of cellulitis affecting the foot, which has been marked off with the felt pen. This will allow us to detect if there's any spread of the infection. When we look at the plantar surface of the foot, we see a lesion underneath the second toe. The patient was largely unaware of this because he has sensory peripheral neuropathy. And this lesion developed as a result of pressure, resulting in an area of necrosis. It became rapidly infected, and the infection unfortunately tracked to the bone, leading to osteomyelitis. This set up chronic infection within the toe, and as you can see, there's a large area of cavitation caused by the necrosis. Here we see betadine being injected into the wound to kill any infective organisms that are there, but of course it can't reach all parts of the wound because the patient has osteomyelitis. Unfortunately, shortly after these shots were taken, it was necessary to amputate this infected toe in order to remove the area of osteomyelitis. Here we can see the large area of necrotic tissue by the amount of packing that it's able to put into this toe. This shows the amount of tissue which has been destroyed by the infection. And because this patient had type 2 diabetes mellitus, the normal inflammatory changes and the normal inflammatory defense mechanisms worked less effectively than in a non-diabetic patient. Here we see a very nice dressing being applied, but this was very much a palliative measure prior to the amputation, which was shortly subsequently required.
All right, so I just want to give you the difference between type 1 diabetes and type 2 diabetes, okay? Type 1 diabetes is called insulin-dependent diabetes, meaning that most of these patients require insulin. It is an autoimmune disease. The beta islet cells of the pancreas does not produce insulin anymore. So insulin has to be injected in these patients. Diet, exercise, and other lifestyle changes cannot reverse the condition. The beta islet cells have been destroyed. The patient is dependent on insulin injection for the rest of their lives. Previously, this is what we know, but we know that to be different nowadays. Type 2 is insulin resistant, meaning that the patient is resistant to insulin. The body does not produce enough insulin, so the body is resistant to it. Diet, exercise, oral medication can help the body produce insulin more effectively. Beta islet cells can deteriorate over time, and insulin injections may be required at some point in the future. And clinical studies right now, one of the most important that says that liver bionucleotides biosynthesis is essential in protecting against vascular complication in individuals with long-term type 1 diabetes. So as you can see, that nucleotides synthesized by the liver, and for you guys to understand that animal liver is very, very high in nucleotides. The only problem is that if you want to get to benefit from the high content of nucleotides, you have to eat the liver raw. Do not cook it. Eat raw liver. I hope you understand that raw liver is very high in nucleotides, and if you can eat and tolerate eating raw liver, then maybe you could benefit from getting nucleotides. Otherwise, you just get a nucleotide supplement like Imurgen that could help in preventing the complications of peripheral vascular disease in long-term diabetes, type 1 diabetes. So let me show you a patient here from Manila. 2018 in January, there was already a necrosis at the leg. This is because of peripheral vascular disease, because of diabetes. Secondarily infected, the wound was left in January 18. They started to do, it progressed January 24, 2018. After taking, they gave sprayed nucleotide liquid on the wound. And you can see that this is after 2 months, and the current condition of the skin after cleaning the wound and spraying, putting a few drops of dietary nucleotide liquid on the wound, it's already almost completely healed. That's good, right? Good for you, bad for me, because I lost 15,000 pesos. Now, I'll show you this. There a video? No, there are no video. Another diabetic foot. This one is in Malaysia. This is a peripheral vascular disease in 2000. You can see the crusting and very bad condition of the skin. If left neglected, this would lead to amputation. What we did was also the same thing. We sprayed and dropped dietary nucleotide on the wound to hydrate it. And after that one, September, this one is October 28. You can see already the wound or the drying of the better condition. And thank you everyone for listening. I hope I successfully ruined your lunch. Remember that fasting is good for you. Thank you everyone.